Good evening, one and all present in this session. And I welcome you all to 79th AIOC 2021 Virtual International Conference. And to start with the session, I request our moderator, Sir Professor Ahmed Ismail, to unmute themselves and they can start their presentation. Over to you, sir.
Okay. Thank you very much for your introduction. And first of all, it's our pleasure to join the All India Society of Ophthalmology. And we would like to thank all the workers and the technical support that they help us throughout the last few days. And special thanks to Professor Namrata for allowing us today to be with you. Our cornea symposium will be in four main presentations: Professor Shurbagi from Tanta, Professor Katamish from Cairo University, Professor Regal from Ain Shams University, and Professor Saad from the south of Egypt from Asyut University. I am myself, Mahmoud Ismail from Al-Azhar University, Cairo. Of course, for a small refreshment, in the last few months and in the last year, we had a very bad experience with the epidemic of coronavirus, and few things were added in the field of ophthalmology, because all over the world we were concerned about the viral infection that we have been suffering, all of us. But let me remind you first that the Egyptian Society of Ophthalmology was founded in the year 1902, more than 115 years ago, and this is the venue of the wall of fame that we had in our society, explaining all of our professors. We had an avalanche of webinars because of the epidemic of coronavirus, and we had a lot of participation from India, and we can see here Sunita and Susan Jacob, Dr. Agarwal, Dr. Sharma, all of them around the world. My participation was to introduce to you a new concept of cutting of the cornea, the femtocut by decagon. Decagon is the 10th-point cut, which will fit from donor to recipient as if it is a puzzle. So you can use it in penetrating and even in deep lamellar, like in this case that I'm introducing today. We all know that deep lamellar, with the worst cornea that you have, you can get the best result outcome, because it does not depend on the endothelium whatsoever, and it converted the surgery of cornea transplant to a extraocular surgery instead of being intraocular surgery. And as you can see, this is a high-speed movie. We can follow our steps, the usual steps of deep lamellar, and you still have to remove the distal endothelium complex and use the worst cornea in your inventory to get the best result, as we have said today. So I will just keep this up to this point, and I would like to thank you, and let me introduce Professor Tamer Ragal from Ain Shams University, who will be speaking about misleading corneal emphysema. Professor Tamer, please.
Good afternoon, everybody. Good evening in India. Thank you for the All India Ophthalmological Society. Thank you, Professor Ismail, for inviting me to talk in this good conference, or one of the major conferences all over the world. I'm going to talk today about the surgical emphysema during DALK procedure, or deep anterior lamellar keratoplasty. Can you see my screen now?
No, sir. Please share your screen.
Is it apparent now?
Yes, sir. Your screen is showing, but PPT is not showing.
Sir, we can see your screen, but not the presentation, sir.
Now now the presentation is on.
No,
it's not open yet.
Not yet.
Can you see it now?
No, sir.
No.
No, sir, not yet.
It's shared, and I now.
Sir, please stop share. Share again.
Can you try to open it, Tamer?
It's open already. I'm going to stop
share
sharing.
Yes.
I'm going to stop sharing again, and then I'm going to do share screen.
Tamer.
Can you see my presentation now?
No, sir. No, sir.
No.
No, sir.
Tamer, can you hear me?
Yes, I can hear you.
Are you joining as a panelist or as a participant, ordinary participant?
No, through the email.
As long as I have the share screen button, this means that I'm a panelist.
Yes.
Okay, just check again.
Can you see? Now it's open. Can you see it now?
No, it's not shared yet, Tamer.
You can see my screen.
No, sir. No, sir. Not see. Yes, sir. See.
Now it's seen?
Yes,
Yes.
sir.
Okay.
Yes.
Open, yes.
Okay.
Yes, okay.
Okay, very good.
Yes.
Okay,
Sir.
I'm going to talk about the surgical emphysema or the corneal emphysema that can occur during bulk or deep anterior lamellar keratoplasty. As we all know, the deep anterior lamellar keratoplasty is the standard of care of stromal opacities or stromal dystrophies or ectasias. The idea is to separate the descemet membrane from the stroma through injection with a big bubble in this potential space. The desirable effect is to have this big bubble to separate the descemet membrane from the stroma, but the undesired effect is to have some sort of bubbles escaping to the stroma, like seen in this histopathological picture. I'm going to share with you a few videos about the DALK procedure, showing the idea of emphysema and how it can occur in different appearances. As we can see here, after trephination of the cornea, partial thickness trephination and injection of air, we can see here type 1 bubble, big bubble, and we can see here some sort of emphysematous tissue making the cornea opaque due to escape of air in the stromal spaces. I'm going to continue the surgery, the first surgery to the end until bearing of the descemet membrane. Here I'm doing lamellar keratectomy, removing the superficial corneal lamellae. After that, the removal of the complete removal of the superficial stromal tissue, putting some viscoelastic on the surface of the corneal stroma to make the air escape apparent and at the same time to make it slow. Then the brave slash, opening the deep stroma to get the air outside and to expose the descemet membrane. As you can see here, an air bubble is entrapped in the viscoelastic material. Then the surgery can be completed easily after that procedure with blunt dissection of the deep stroma from the descemet membrane. As you can see here, the few areas of emphysema or corneal emphysema make the surgery easy because we have plenty of tissue still clear. This is the final step of the dissection. And back again to the literature, we have a paper here talking about the emphysema and the big bubble and how it's seen with intraoperative OCT. If we have a clear tissue or an areas with no emphysema, we can see through the intraoperative OCT that we can delineate the posterior part of the stroma. This makes that sure that we have an air bubble here. We cannot see the descemets, but we can see the separation by this distinct back surface of the stroma. This is the best result you can have from the big bubble with few emphysematous tissue. Again, I'm going to show you another behavior of the big bubble and another behavior of the surgical emphysema or corneal emphysema. Now I'm injecting air in the deep stroma. Now we can see here that big bubble is formed, and this can be judged by the dark or opaque edge of the big bubble. But we have more emphysema than the previous tissue. Still, we have clear tissue. We can open the potential space, and we can continue the procedure without difficulty, because we still have some clear stromal tissue to do the separation or to do the maneuvers through it. Again, this procedure is continued to the end, easily dissected tissue, although we have surgical emphysema here, but still we have clear tissue to go through and to dissect the stroma from the desmus membrane. For the time being, I'm going to go to the third video, another case, injection of air, too much emphysema, much more than the previous one. We have still very small area of clear tissue here, but most of the cornea now is emphysematous and opaque. Still, we can do the procedure, or continue the procedure much difficult than the other one, but you can see here that the air escaped from the potential space, and we can continue the procedure as usual. This is another case. I'm going to escape to the fourth case, another case of injection of big bubble. We can see here that the edge of the bubble is clear, and we have the big bubble already formed, but the cornea is completely opaque now due to the emphysema escaping of the tissue or the air to the stromal tissue. Now, we can, here it's not that easy because you cannot see properly the air escape through this opaque cornea, but still you can continue the procedure and you can end it without further conversion to penetrating keratoplasty at the end. Now we can see here some bubbles in the anterior chamber escaped through the trabecular meshwork. So the emphysematous tissue still make the procedure more difficult than in clear cornea, but still you can work on and you can continue the procedure safely. Back to the literature, in the opaque area of the cornea, when you have something like that, this opaque part, small clear part, the OCT, anterior segment OCT, can delineate the area where the cornea is clear, but cannot delineate the area which is emphysematous, because the now the OCT picture cannot go through this opaque tissue. I'm going to the last two videos showing more aggressive emphysema, more severe emphysema. Now, injection of air of all the cornea is opaque, outside and inside the trephination area. Still, I'm going through the procedure, although I'm not sure about the big bubble, but I'm trying to dissect as much as possible. Okay, now it's going to the proper space. I'm going now to dissect. It's succeeded. It's a succeed procedure to the end. But see here, this is the last video. Injection of air after going to the deep stroma. Make the cornea, as you see, completely opaque. Here I'm not sure, is it formed bubble or not? Although the tension is not that hard, I'm not sure. I thought that I'm here in the proper space, and I'm going to open the potential space as I imagined. And I saw air coming to the viscoelastic. I thought that I'm in the proper space. I'm dissecting properly. Now I found myself in the anterior chamber. So this is a case of failed DALK and was converted to the penetrating keratoplasty procedure. Back to the literature, in case of opaque cornea like this, the anterior segment OCT cannot find anything in the deep part. So you cannot judge with the anterior segment OCT. Now I'm working with the anterior segment OCT most of my corneal transplantation procedures, and found that if you have a severe emphysema, it's difficult to delineate the posterior part of the stroma and to judge that the big bubble is formed and the descendants is separated. And back again to the literature, the anterior segment OCT can do very, very good maneuvers during DALK. We can make sure that we have a good depth in the trephination areas. We can make sure that we have a good depth in the injection site of air through the cannula. We can make sure that we have some sort of emphysema, but we cannot make sure that we have the descendants detachment in case of severe emphysema like that. Again, we can make sure that, and we are here exposing the descendants membrane and it's intact. And now the descendants membrane is completely intact, as you can see after removal of all the stroma. We can put the new graft and you can see that it is attached to the descendants membrane at the end of the procedure. So the anterior segment OCT can help to many steps in this procedure. But although penetrating keratoplasty has its inherent risk of open sky complication, the DALK procedure still has its difficulties and complications. Extensive corneal emphysema can affect the outcome of DALK. Intraoperative OCT can help in visualization of many surgical steps in DALK procedure, but not the big bubble in presence of emphysema. So if you have an extensive emphysema, take care during your dissection and take care during your procedure. And thank you very much for your attention.
Thank you. Can you remove the alarm, please? Thank you very much. Thank you very much, Professor Tamer Raggal. Very interesting point of view. And now I would like to invite Professor Sameh Sharbagi from Tanta University to speak today about very, very important issue that we have in Egypt. And I hope you don't have it in India, which is the Amoeba Keratitis with all its problems and complications. Professor Sameh, please. Dr. Sameh.
أيوة السلام عليكم. بسم الله الرحمن الرحيم. My ladies and gentlemen, I would like to present today one of the becoming most of the corneal infection here is Amoeba Keratitis. At first, yes, Amoeba Keratitis. We would like to know what is the resistant ulcer, because this is the most common resistant ulcer, the ulcers that not heal with treatment or even become worse. In the top of resistant ulcer is amoeba, followed by fungal and resistant bacterial strains and degenerative ulcer. We just published this since 2 months in the clinical ophthalmology, Amoeba Keratitis in Egypt, and our plan of treatment. In our treatment, there are our study, retrospective study 4 years before, we reveal 57 cases of Amoeba Keratitis, diagnosed clinically and confirmed by lab work and in vivo confocal microscopy from August 2016 to August 2020. We canceled 13 cases as they not follow the up of the instructed period. Only 44 cases were followed. We found that contact lens is responsible for 65.8% of these cases. In 86.1% presented with severe pain. In 65.9% with perineural infiltration, pseudodendrites in 43%, and stromal infiltrate in 59%. detection of cancer amoeba, only 25 cases were diagnosed clinically and confirmed by lab work and in vivo confocal microscopy, while 19 cases diagnosed by history, manifestations, and the response of treatment. These many organisms on the top of this, Acanthus amoeba castellani is responsible for Acanthus amoeba keratitis. We can get a systemic manifestation with these cases as dermatitis and pneumonia. Acanthus amoeba is found in contact lenses. Contact lens solutions, especially homemade, soil, air, oral and nasal mucosa, and infected water supply. Trophozoite form and cystic form. Actually, trophozoite is active invasive, but the most dangerous is cystic, as it is double-walled cyst that resists the entrance of anti-Acanthus amoeba drugs. Risk factor, contact lens, trauma, especially vegetable trauma, and contaminated water. Usually, infection occur in healthy cornea, and this is different than other types of corneal infection. Manifestation occur usually 10 days of infection, and Acanthus amoeba represent 1% of the corneal infection and must be differentiated with other resistant corneal ulcer. This is, as we said, it can occur in healthy cornea or an abrasion. No need for abrasion. It can adhere to the epithelium and then all the layer of epithelium and rupture of Bowman's membrane and go to the stroma till the end. And rarely it invades the Descemet's membrane or endothelium. The most presenting manifestation is severe pain out of proportion. Patients coming to us with more or less quiet eye, but he had a very severe pain. And this is usually because Acanthus amoeba, either the trophozoite form or cystic form, can predicate the position or infiltrate it around the corneal nerve and also takes the radial pattern of corneal nerve. We must know well, epithelial lesions may be SPK, superficial pancreatic keratitis, or dendritiform lesion, and this is very dangerous because it is misleading from dendritic or herpetic keratitis, and you will present a case of like that. It may be presented by microerosion, ulceration on dendritic lines between epithelial cell, and this is one of the pathognomonic signs of the Acanthus amoeba. For example, this is a dendritiform lesion, 100% diagnosed as a dendritic ulcer or amoeboid ulcer, but actually it becomes worse with antifungal treatment. And when we do scrap culture and in vivo confocal microscopy, we diagnosed as Acanthus amoeba. A stromal lesion, many shapes can be presented as patchy infiltration, diffuse infiltration, perineural infiltration, and this is responsible for the severe pain of this type of corneal infection. Will be ring infiltration. For this reason, any ring stromal infiltrates must put Acanthus amoeba in the first. Satellite lesions and very characteristic absent vascularization, and this is totally against fungal keratitis. This is patchy infiltration, cheesy-like material like that. And this perineural infiltration, this is a corneal nerve, and Acanthus amoeba around take the radial perineural infiltrations. And this is the ring infiltration, satellite lesions and perineural infiltration, and this is a diffuse infiltration. Usually, there is no or very rare to find an anterior chamber reaction and secondary coma, but we will present a case like that. This is perineural patchy infiltrations and diffuse infiltration with anterior chamber reaction and hypobium. Also, we can get anterior scleritis. For this reason, any infective corneal ulcer associated with scleritis, put in your mind, it may be Acanthus amoeba. Diagnosis, confocal microscopy, chronic course over weeks or months, history of exposure to risk factors, especially contact lenses, Also, the negative culture of bacteria and the fungal and the viral, lack of response to their medication, and the presenting symptoms is a severe pain out of proportion. This is the shape in confocal microscopy. Cysts appear as highly refractile superficial structure. Lab work, we must make a vigorous corneal scrap, corneal biopsy, if possible. From the contact lens, we cut contact lenses into small pieces and to be cultured, and the solution of contact lens. As we said before, vigorous. If I suspect a case of a cancer amoeba, I must make a vigorous scrap of the cornea, and it must be fixed immediately by methyl alcohol to prevent the rupture of trophozoites that may occur with dryness. Very special care when we take this scrap from suspected case of a cancer amoeba, immediately fix it with alcohol because it can be ruptured by dryness. Stain this specific calcifluor white. The best cysts appear at an apple green structures. Gems stain, gongy red stain, gomerymethamine stain, periodic acid shift. Nutrient, blood, and chocolate agar for the culture. This is the shape of cyst stained with calcifluor white, and this stained with gemsa, and this is in culture on a nutrient agar. Sure diagnosis by PCR and impression cytology. Thus, to summarize, diagnosis, initial diagnosis by confocal microscopy give us an initial diagnosis, but be sure by PCR and impression cytology. Highly suspicious lesion clinically, dendritiform lines between epithelial cell, radial perineural infiltration, and ring stromal infiltration. Protocol of management, we must specific treatment, adjunctive treatment, surgical treatment, and follow-up. Treatment, not like other types of corneal infection, it is very difficult because the cystic form resists anti-amoebic therapy. Also, there is no enough retrograde study for efficacy of these drugs. And most recently, prevention is most important. As we said later, vaccination begin to do for cancer Amoeba Keratitis. How can I begin? Stop all anti-infective drug for 1 day, then do corneal scrap. Put an initial diagnosis depending on history, ulcer feature, and response to drug given. We begin empiric treatment according to the initial clinical diagnosis. Modify the treatment according to the culture results. If the culture results positive and the patient is improved, we continue the treatment. If also it is negative and improved by initial therapy, empiric therapy, we can continue. But if it is positive and not improved, we add systemic drugs. If it is negative and not improved, we must take biopsy. It may be mixed infection or other media. We used in our studies or in our university proline and the polyhexamethylene biguanides. This is the specific, but other drugs had an anti-amoebic effect as neomycin, oral itraconazole and fluoroconazole. Pure honey is excellent. It can rupture the cystic form and also betadine. But the specific only is proline and the PHMB. Combination, as we said, the cystic form resist. Combination of 2 or 3 biocides is essential as cystic form is resistant. We use this one, proline eye drops, and Baquacel. We prepare this from coming from USA. We take from this and make the preparation. And this is the most recommended combination is PHMB and proline, maybe PHMB with betadine, neomycin, proline, and fluoroconazole. All these are recommended combination, but this is the most effective one, and we give a good results. Combination of proline and the PHMB, we must continue for 1 year. The first 3 days every half an hour, The second 4 days is 2 every 2 hours. This is the first week. Maintenance dose, second week every 3 hours, third and fourth week every 4 hours for 1 year, 4 times per day. As we said before, prevention is more important. Now, education for contact, as we said before, and vaccination. Injection of Acanthus amoeba antigen IM or subconjunctivally give us immunoglobulin appeal that prevent the adherence of Acanthus amoeba to the corneal epithelium. This all the study done in order to prevent the adherence, or as the spikes of Acanthus amoeba can adhere to unhealthy epithelium. For this reason, vaccination is directed to this position. Also, we give a systemic drugs to prevent corneal melting as tetracycline and oxytetracycline. Autologous serum of the patients is marvelous. We add it in every case of infection, and cyclosporin can be used. Some cases improved with medical treatment, as case 1. Here, 17 years age, female by contact lens from pharmacy, presented with patchy and peridural infiltration, and this is the follow-up of the cases till the end. Case 2, this is presented, 21 years, female with contact lens, rented contact lens for hairdresser with ring infiltration. Third case, and this is the misleading case, the dendritiform shape of the Acanthus amoeba, and this is the patient, actually it is not improved well because the toxic effect of long-term antiviral drug given before. And case 4, and this is, as I told you, this is anterior chamber reaction is rare, but in this case we can find ring and the patchy infiltration with anterior chamber reaction and hypopyon. Okay, but we do at the end A, B, C, D. We do a amniotic membrane in this case, and it is very, very wide.
Sorry to interrupt you, sir. Could you please sum it up in next 30 seconds? We are running short of time.
Okay.
Yeah. Thank you so much,
we
sir.
Proceed for conclusion, Dr. Sameh. Yes.
Conclusion, we can use adjunctive surgical therapy, argon laser, cross-linking, amniotic membrane, and membrane transplant, argon membrane, and this is very nice. Role of argon membrane here we put, and this is very useful in these cases. And this is the last case. It is we use medical treatment, amniotic membrane, and finally penetrating keratoplast. Thank you very much.
Thank you very much, Professor Sameh. Very interesting. Professor Sameh has a very alarming post in the social media about the use of, with ignorance, the use of contact lenses, that he is always in our media presenting such alarming advices, but sometimes people, they don't care. Now we will shift to a new presentation from Professor Tarek Khatamish. He will, we will live with him a very thrilling experience through doing phygomulsification through the tough DUA layer in big bubble talc. Please, Professor Khatamish from Cairo University. Fadal.
Good afternoon, everybody. I am very happy to represent the Ophthalmological Society of Egypt in the All India Ophthalmology meeting. And I would like also to thank Professor Dr. Mahmoud Ismail, our moderator, for his great efforts and for the kind invitation. I will share my screen now. Actually, it is a pre-recorded presentation, so I will start now my presentation. Phygomulsification through the tough DUA layer in big bubble talc, a thrilling experience. Patients with combined advanced ectasia and cataract present surgical challenges. There are several approaches for this problem. the most common of which is a two-stage procedure in which a corneal graft is followed by cataract surgery at a later date. With this sequential approach, the patient requires multiple surgeries under anesthesia and visual rehabilitation is delayed. The second option is a corneal graft performed simultaneously with cataract extraction and intraocular lens insertion. This triple procedure has several benefits over the two-stage technique. These include a shorter period of visual disability, fewer follow-up visits, and less cost to the patient. When combining DALC and phacoemulsification, we have to know that the pre-Descemet's layer, the DOAS layer, is much tougher and resilient than Descemet membrane and could withstand a pressure of around 700 millimeter mercury. DOA layer also allows a clear view for performing phacoemulsification with the added benefit of its toughness, which can maintain a stable anterior chamber for cataract surgery. When doing phacoemulsification through DOA's layer, we have to do it when we have what we call it the big bubble type 1. So we have to know now the difference between big bubble type 1 and big bubble type 2. Big bubble type 1, it usually starts from the center to the periphery, as you see, has a maximum diameter of 8.5 millimeter, and the plane of separation is between the stroma in front and DOA's layer behind. And this is a characteristic wide edge of big bubble type 1. After removing the stroma, we'll be having the floor formed of this tough layer and rough surface as well. On the other hand, big bubble type 2, it usually starts from the periphery to the center and has a large diameter, may reach up to 10.5 millimeter, and the plane of separation is between DOA's layer in front and this membrane behind. And this shows the characteristic clear edge of big bubble type 2. After removing the stroma, we'll be having the bare Descemet membrane, which is smooth and very fragile surface. This shows how much pressure could be applied to the DOA layer and still it resists rupturing. On the other hand, type 2 big bubble has a very fragile Descemet membrane and it can rupture very easily. So after this introduction, we will go to our case today. A 60 years old male patient, single-eyed, has advanced keratoconus with nuclear cataract plaque-free, and he has a very sunken globe and a very narrow palpebral fissure as well. The treatment options, as have been mentioned previously, we either have the sequential approach, doing DALC then phaco, or doing phaco then DALC, waiting for a few months in between, or doing simultaneous approach, doing DALC and then doing phaco through DOA's layer in the same setting, or doing phaco first and doing that. In this case, due to the strong and tough properties of DOA layer, I have chosen to do this option to do DALC first and then to do phacoemulsification through this tough layer. This is the case. As you see, as I have mentioned, the patient has a very sunken globe, which makes anatomical difficulty during the operation. He has as well a very tight palpebral fissure, so I am doing for him lateral keratotomy to improve the field of operation. Doing DALC first, as I have mentioned, we do injection of air by blunt cannula, and we have got now the big bubble type 1, as you see. Continuing the DALC operation as usual, removing the stroma, opening the roof by the brave slash, and then we cut the remaining stromal flaps to expose the DOA layer with its characteristic rough surface. This is the DOA layer with its characteristic rough surface, as you see clearly in this video. We start now doing phacoemulsification. We do trypan blue staining under air, and then we inject a cohesive viscoelastic as usual. Construction of the fake wounds is very important. We have to support the globe by counter pressure by equilibrium forceps, not to make rupture of this membrane. And then we'll start now the usual phacoemulsification by doing capsulorhexis, starting by needle and then continuing with capsulorhexis forceps. Hydrodissection as usual. As you see, we are doing all the steps of phacoemulsification as if we are working through a full thickness cornea. You see, I'm doing now nucleus rotation as usual. Starting phacoemulsification, whether to do it by the divide and conquer or the stop and chop technique. But look here, what will happen now? You see, I will do it now in slow motion. You see this, the small, tiny perforation of dual layer. But fortunately enough, this small, tiny perforation was at the very periphery of this membrane. You see how much pressure is applied during nucleus fracture. This is the BSS coming out from this tiny perforation. Chopping technique, as if you are working through full thickness cornea, but remember we are working now through only the Duas layer and this membrane. Again, this to show the BSS jet, but fortunately this perforation was at the very periphery of this membrane. And this is the last piece of the nucleus. And this is, I'm drawing the surface just to remember you that we are working through this tough Duas layer. Continue the operation with irrigation aspiration as usual. Implanting the intraocular lens with bimanual manipulations to put it in the capsular bag. You see the clarity and the view is excellent. Again, drying the surface to show you that we are just working from the dual layer. Now we leave the patient and go for donor preparation. And then we'll come to the final step, which is the ordinary step of suturing the graft to its bed. I just want to show you a very small clip now again. You see this clip? You remember this is tiny perforation. This perforation has an impact on the post-operative course, and the patient has double anterior chamber, but the double anterior chamber has been corrected very nicely and easily, and this is the outcome after a few days. The cornea is almost clear. Thank you very much for your kind attention, and I hope that the next meeting, the Asian Corneal Society meeting, to be a real meeting and to see you all in a perfect health and a perfect situation. Thank you very much.
Thank you, Professor Katamish. Thank you very much. It's indeed a thrilling experience. Very nice to see how can phacoemulsification can dual layer withstand the phacoemulsification pressure and the jet of BSS coming from a very tiny. It was very thrilling experience, and we are all enjoyed it. Now I will go to our last speaker, and not least, Professor Muhammad Saad from Asyut University from the south of Egypt. Professor Saad will speak about a very interesting topic about the ozone treatment in cases of endophthalmitis and infectious keratitis. Professor Saad, please proceed.
السلام عليكم. السلايد شيرنج. فين طيب يا بابا؟ تعال. فين يا بابا؟ هندوس شير ولا ايه؟
الصوت يا دكتور محمد اعتقد ان
كده الصوت تمام؟
ايوه تمام كده.
تمام يا فندم. طبعا I'd like to thank all the Indian Ophthalmic Society for the invitation. Also thanks a lot for Dr. Mahmoud Ismail for his great effort for preparing this symposium, and greeting for all the speakers for their beautiful and great presentations. Now I'd like to talk about the ozone therapy.
Share your screen, yes.
Okay. مش بيتحرك. I'm sorry. أعمل إيه؟ تعال أنت.
You did it and then you closed it, yeah, Dr. Saad.
Yes, it's okay. Is it okay?
Not yet.
No, sir.
Not yet.
No, sir. Please share your screen.
Do you hear me?
Yes, we hear you, Dr. Saad, but share the screen from the green button in the inferior part of the screen. يعني في زرار اخضر كده حضرتك كنت انت دوسته وكنت بتشتغل. Please do it again.
Okay. Just a second.
دكتور محمد دوس على السكرين ده، شير سكرين، وبعدين روح على الديسك توب ونقي التوك اللي انت عايزها. ايوه بدأ. تمام. ايوه خلاص. اوكي خلاص.
Infective keratitis is a common finding in our daily practice. طبعا the main problem with infective keratitis is it needs treatment for a long time, and sometimes there is resistance, and sometimes we got toxicity. So we have other weapons to help us in treatment of infective keratitis, like corneal cross-linking or ozone therapy. Ozone is very effective antimicrobial agent for all germicide, and it has a very beautiful, very strong oxidative effect. It reactivates the antioxidant system. It has anti-inflammatory effect, and it promotes the tissue repair. All these advantages may not be present in other weapons in treating infective keratitis. Now ozone is already used in some diseases like trophic ulcers, ischemic ulcers, diabetic foot, and so on. The forms of use of ozone, starting from the gaseous state, which is unstable, and we can use it, we cannot use it. Saline, ozonated saline, which is our target in this talk. The ozonated saline can live for some time, which is that time you can use it in treating the infective keratitis. Its half-life is about 2 hours and can extend for 24 hours. Ozonated oil had been tried and have been manufactured in Italy, ozodrops, but unfortunately it's not available in our country. These are some literature we share in the process of liposomes, ACTA, liposomes for human in cornea, and use of ozonated saline in vitrectomy in polyton ophthalmology. And this is the way how we can prepare ozone. We use the medical oxygen, the usual oxygen, and the ozone generator. It's not an expensive instrument, and we start to produce ozone for the sake of healing. We can use the usual tear substitutes we are used to use in our country. If the low concentration of ozone just stimulates the immune system, but higher concentration has a very powerful germicidal effect that may extend up to 50 times as the strongest antibiotic we know. So it is very, very effective germicidal tool. We have tried this ozone therapy in a trial study, it's prospective comparative study. Divide the patient into two groups. Group 1, Group A included 13 patients and applied ozone therapy to tier natural eye drops for 3 days every week. Every day he has to put eye drops for every 5 minutes after preparation for 2 hours, and then after that every 10 minutes for another 2 hours. And these 3 sessions in the first week may be followed by another 3 sessions on the next week, the second week. For comparison, Group B has underwent the usual conventional antimicrobial therapy. Our results, this is the difference between the organism, and as we know, it is a different form of bacteria and fungi. And this is the outcome as regard the time for healing. As we see that Group 1 or Group A has more rapid healing, about 15 days, in comparison to the mean time for healing for the Group B was 26. So there is a significant difference between the patients using ozone and other patients. These are some examples. This is patient had an extensive ulcer. After 1 week, the middle picture, and after the second week, there is improvement, a great improvement. Another patient also has a mycotic ulcer and started to heal within the first week, and during the second week it is almost completely healed. Another patient also pre and post ozone therapy within 2 weeks. Another group of patients pre and post treatment. Another examples pre and post. Another example also. All these are examples for patients underwent ozone therapy and the great improvement within the first week, and start the complete improvement usually within 14 days. Another one before and after treatment. Another example, and marked regression of the size of the ulcer within few days. Another example. This is a comparison between anterior segment OCT during the activity of the ulcer and after healing, and we notice the improvement of the size or increase in the size of the ulcer, the depth of the ulcer. So microbial keratitis is one of the leading causes of blindness in our countries. The use of weapons in addition to the conventional treatment may be very beneficial, either alternative or adjunctive to the usual therapy. The advantage of ozone use is its anti-inflammatory effect, bactericidal and germicidal activity, and promotion of the tissue repair. To conclude, ozone therapy may be a very good complementary, effective, and safe technique to help promote healing of infective keratitis. Further studies might be indicated or advised to get more better concentration and more better results. Thank you.
Thank you, Professor Sa. Thank you. Very, very interesting. Actually, I never thought that it is so easy and so. Let me ask you something, and we will start. We have a few minutes for discussion. Can we? Yes. How do you ozonate? Let me turn the word ozone to a verb. How to ozonate the tears? Do you pass the gas through the tears, or what do you do exactly to make the tears natural to be ozoned?
Exactly. Under complete sterilized condition, the nozzle of the tube coming from the ozone generator introduced within the nozzle of the eyedropper and wait about from 10 to 20 minutes. This is quite sufficient to ozonate this saline, this tear substitute.
So the next question is, if we ozonate this eyedropper, okay, العبوة دي, if it's ozonated, it will be ozonated forever, or this gas will evaporate and this vial is only suitable for today? Let's say it in other way.
Half-life of ozonated saline or ozonated eyedropper, this is the maximum concentration. Next 2 hours, it will drop to the half. And so use it within the first 4 hours and repeat the session for 3 times per week. This is my
that's why you use it 3 times per week. Yes, because I thought that we can ozonate the antibacterial or antimicrobial eye drops that you use, and we give it back to the patient and we go home, but this won't work because it's not viable for, so it's ozonated now and it will be functioning now, and that's it.
Yes. The other alternative is the ozonated oil, sunflower, which is synthesized in Italy. I have used it, but it's not available in Egypt. It may take a longer time, but I think this method is more economic and more practical for our patients and very cheap. Does not cost the patient anything.
It's nothing, yes. Yeah. Thank you, Professor Saad. And I would like to share with you also the experience of Professor Katamish when he said thrilling. Yes, it is really thrilling. Did you think, Professor Katamish, when you are doing the phaco under did you took some pills of Andral or something for the palpitation, or you went on?
Yes, I agree with you. It was very thrilling, but fortunately enough, I found the DOAS layer really a very tough layer. So as you see in the video, I have performed all the maneuvers of phaco with the fracturing of the nucleus and the stress of the fluid. And in spite of all these maneuvers, during the operation, I got some confidence to continue. So of course, you cannot do all these maneuvers except with type 1 big bubble with a dual layer. But if you have a type 2 bubble, it's impossible to do this technique through the fragile Descemet membrane.
Even more, you had a very tiny perforation and it did not extend.
Yes.
That means that it's still tough to withstand a of course, it's a tiny perforation, but it's a perforation. So if you are doing phacoemulsification and you have a tiny perforation in the posterior capsule, usually it extends. So having a tiny perforation, this is even more to prove that your point of view.
Yes, exactly.
I did one case before, and it was just as you said, you have to select it, but I covered the dual layers with submethyl, and it was not functioning. I see that you didn't cover anything. You're just working.
No, working through it and just waiting, because when the dual layer is dry, it will be not as clear as when it is wet. Yes. So just continuous waiting as if you are dealing with a full thickness cornea.
Yes, of course. Professors, thank you, Professor Katamish, and very well done.
Can I have a comment, please?
Please.
Of course, I have 2 comments on Professor Dr. Tamer Raggal presentation. We all know that Professor Tamer is a great lamellar corneal surgeon. We know all that. The first comment is I have a tip. Of course, all of us have the experience of getting this huge whiteness of the cornea, but I'm now trying to inject very deep. So I am insisting on taking about and go as deep as 85% of this pachymetry. And when you inject very deep with a blunt cannula, there is no time for emphysema. You are very near to the Descemet membrane. since once you start injecting, you will find the bubble form immediately without any emphysema. This is a tip which helps in this regard. The second comment is you described that when you have a diffuse whitening and you go open the brave slash as if you are gambling whether there is a bubble or not. My comment is you have to make as much as deep dissection. And since you have this huge emphysema, you will have bubbles in the anterior chamber. So if you find the bubbles in the anterior chamber in the center, this means that you don't have a big bubble. And so you have to continue manually. But if you have the bubbles displaced to the periphery of the anterior chamber, you can go and do your brave slash. But you have shown us great videos and great work. Thanks for your talent, of course.
Okay, good comment.
Thank
Dr.
you, Professor Kapamish.
Yes. Do you like to say something?
Very good, very informative comments, Professor Tarek. For sure, Professor Tarek is one of the best adult surgeons all over the world, I think. And his talent is in this surgery. We can see very good comments. Yes, I totally agree. Still, if we are going to use the anterior segment OCT, we can make sure that we are very deep in the stroma to inject the big bubble. And this is a very good comment. I totally agree with Professor Tarek.
Thank you, Professor Tamer. I think emphysema happens more with younger patients more than adult, mid-adults. يعني انت عارف دايما اليونج keratoconic patients, they are more liable because they have the tissue more labile more than the or long-standing people with or terminal keratoconus. Usually they have more emphysema than short-durated. But as Dr. Kapamish said, we will do our best to prevent it. Professor Sameh, thank you for your excellent presentation. Your presentation was thrilling about the Acanthamoeba, and it's very informative. And on behalf of myself and all our colleagues from Egypt, I would like to encourage you more to make every possible way to announce the very nice announcement that you sent to me about, and I really ask you all to forward this message on your social media of Professor Sameh Shourbaghi, because prevention is better than cure. I would like to conclude the session and thank you very much. Thank the All India Society, and we are, as Professor Tarek have said and Professor Saad have said, we are looking forward to have you in Egypt. The next meeting, inshallah, will be here in Cairo and in association with the Egyptian Society of Ophthalmology. Thank you very much. Thank you for the technical support and thank for Professor Namrata once again. Thank you very much.
Thank you very much.
Thank you so much, sir, for this wonderful